I can't imagine. I mean, medication errors. That has got to be one of the most scary things to do, I think, is making sure you have the correct dosage. So that's why you do those single checks, double checks, and triple checks.
It's important in any type of nursing, obviously. When you're giving a medication, you can affect these people big time. Sometimes it's as simple as a vitamin, but sometimes it's something as big as a heart medication. And you, in any type of nursing, you need to be extra careful about that. But when you're talking about a neonatal population and their bodies are so tiny and so fragile, they just have so much less capacity to be able to compensate for any mistakes.
So we get used to, a lot of times, it's always for a Zofran. We give a half a milligram or a milligram of Dilaudid, whatever. We get used to giving these certain dosages because it's not weight-based, you know? It's like they're an adult, it simplifies everything. But I imagine because these weights fluctuate a ton. And so,
there's a huge difference between a 500-gram baby and a 5-kilo baby. There's a huge difference. And so you're right, like we can't just give a standard medication for everybody. Everything involves calculations.
Everything involves calculations. Does that get frustrating, or you just get used to it?
You get used to it. You know, everything that we talk about, we don't talk about standard like, oh, we give this dose. Everything we talk about is this many mils per kilo. Everything is weight-based because there's a big difference in these kids. So, it's just, it's part of the job.
I hate that.
So if you don't like math, maybe the NICU isn't the place for you.
Okay. Family's a big thing. I've always heard, I heard this in nursing school, seen it in practice. It's not the children, it's not the baby, it's the family that can drive you crazy. Again, with good reason. My mom, if there's, and I'm a grown man, if I'm sick in the hospital, my mom is gonna be fucking nuts. If I'm not wearing a coat when I go outside, she flips her wig. And so, in that respect, if you have a parent that is really overwhelming for you, what kind of thought process goes through your head? How do you manage that to be able to say, I'm gonna be able to communicate with this parent and make things go well? Because a lot of times, family, visitors, anyone can interfere with your care. I imagine it comes to a point where you have to say, I need you to step out of the room sometimes.
Oh, I mean, absolutely. We get those instances where we have to say, hey, we've got something big going on right now. We need you to just step aside for a moment. But honestly, those are rare. For the most part, we understand where these families are coming from. It's easy sometimes to get caught up in the day-to-day of, hey, I'm just trying to do my job. You know, night shift is kind of nice for the sense that we get a little more privacy, it's a little more quiet, so we can just kind of focus on doing what we got to do for the babies versus trying to please the family. But at the end of the day, that's what it's all about. I think for me personally, I've had kids in the NICU myself, and I just have to step back and remind myself how it feels to be in those shoes. You had this baby, you had this thing that's like your most important thing in the world. And you have to leave it.
Thinking about for the last... That's been messing with your life for like the last
That's been making you sick every morning for the last
it's been making you
7-8 months. And your whole world changes. And
your whole world changes.
Universe shifts to this little person. And then imagine having to say goodbye and leave your little person in the ICU in the hands of strangers.
So I guess it's very important to develop that trust, you know, with the family. That way when they go home, they know that they're in good hands. You know what I mean? Because if you have a nurse that comes in, like you were saying, that says, listen, I'm just here doing my job. That would be the last nurse that I'd want.
I'm clocking in, clocking out.
Taking care of my, be like, I'm going to stay the night tonight. Like, and our parents allowed to stay the night?
Yeah, so NICUs are transitioning to the single family room unit, where it's more like a typical ICU where each patient has their own unit. Typically, neonatal ICUs have been an open bay, like they are at my current hospital,
like
where we've got 6 babies in a room.
Okay.
And so we don't have any room at the bedside for parents to sleep.
Gotcha.
They can visit, they can hang out as long as they want, but they can't actually camp
like
there.
Pop a cot up. And,
right. So we've got rooms in the hospital they can stay at for free a couple nights a week if they want to take advantage of that. But a lot of NICUs nowadays are transitioning, and single family rooms give that parent a chance to stay in the room with their baby and participate in all the care.
Absolutely,
which is really great. There's tons of studies out there that show that that's really beneficial for the family, for the coping, and for the long-term
I don't even
wellness.
think you need a study to know that that's a good idea.
It's actually harder for the nurses, though. It is harder for the nurses.
Is it?
And so I think that's why you'll see there's a little bit of pushback. Because we can't help each other as easily when
true. Yeah, you're right.
When there's walls between us. We can't see what the other person is doing at the end of the hall and be able to run over there and help them. So it creates a little bit more difficulty for the nurses, for the benefit for the parents. So it's all a matter of just weighing those pros and cons.
You're in school.
Yes.
Tell me about that.
I'm in school getting a doctorate of nursing practice
Okay.
to be a neonatal nurse practitioner, which pretty much limits me to working just in a neonatal ICU. So I will be specializing in high-risk infant care.
Now, see, I think that's it's a big misconception that people have about nurse practitioners, that like they're only good for primary care. The only thing they can do is do outpatient visits, and they don't realize that because usually people associate physician assistants with doing things that are more hands-on, surgical type stuff and stuff like that. But it's the same exact thing for NPs. You've got NPs in ICUs all over the place.
What's really cool in the neonatal ICU is that the NPs can do pretty much everything the doctor can do. The NPs really work side by side with the neonatologists in our unit.
Gotcha.
And they take half the patients, and the neonatologist takes half the patients. When one takes a break, the other one takes over, and they're very interchangeable.
Oh, wow. Okay.
So what I love about what I'm getting into is it's very specialized, yes, but I'm also going to have a ton of autonomy. I'm really going to be able to work side by side with the doctors, really utilize my critical thinking to establish these plans of care for these infants, and that makes me super excited. I'm really, really pumped about getting to take my care of these kids to the next level.
There's a lot more accountability, and there's a lot more. I mean, not to say that it's all, it's all on the doctor or the MP or whatever, but it's kind of all on the doctor and the MP. They're making the calls, right? If anyone makes a mistake down the line, it could be for whatever reason, but does that make you nervous?
Oh, absolutely. And I think if there's any doctor or nurse practitioner that doesn't have a little bit of nerves from the idea of that buck stopping with them, then that's maybe a little more scary.
Yeah, absolutely.
I mean, I'm extremely nervous about stepping into that role and wearing those shoes. That's what the training is for. That's what the schooling is for. That's the nice part about working hand in hand with the doctors, is that there's always going to be somebody that I can talk to and kind of confide in, and we can share ideas. Now, in a code situation, it's on me. I got to run that. I got to handle it. I have to resuscitate and direct the team. And that's something that I'm going to have to learn through the rest of my training, is how to get the confidence to do that effectively. But it's absolutely terrifying. It really is. But no pain, no gain, right?
Yeah, no, absolutely.
The wins will be big, and it'll be worth it.
Now, the code situations that happen, you've worked at several hospitals, is that right? Or
Yep.
Okay, so how well do they typically run in the neonatal ICU? Have you felt like it's kind of a well-oiled machine, or is it more like it's kind of a little bit more scrambling because it's a baby?
Well, we are all trained on babies. We all within the unit respond to our own codes. We have our own team, and we are so specialized and familiar with this type of patient population that it really is a well-oiled machine.
Okay.
I mean, some codes are always going to be smoother than others given the circumstances, but it's incredible in a code, the people that come together. It's like everyone just kind of knows, okay, these are the jobs, what's not being done, where can I be? And then it's really up to having a strong leader, a strong doctor or nurse practitioner up there directing what needs to happen. It's all about good communication, and I think my team has been incredible. I've always been blown away at
That's
NICUs
good.
and their ability to come together and make it happen.
Yeah, and something that I haven't thought about, they don't have much of a patient history, do they? Right?
No.
I mean, they've got these issues, but I mean, we'll have someone as an adult come into the ER, the coding, they'd say they've been through a couple rounds of CPR or whatever, fire brings them in. They've got this history that's so wacky. They've got all these renal issues, and they smoke crack. You don't know when the last time they smoked is, or when they smoked meth, or whatever it is. So they've just got these long, extensive histories where there could be so much that could be what's causing what's going wrong.
Yes.
I feel like there's a lot more to consider. So that didn't really occur to me until now. That you guys are so specialized, and you've done this so many times with the little ones. And there's not too much of an outside influence.
So they don't have any allergies. They don't have a history of this type of failure, that type of failure, or different medications. We don't have to worry about contraindications between medications. Like we know a lot of these kids we've had for a while. We're familiar with them. We know exactly what their entire story is. We know what they've been having going on since birth.
Yeah.
So you're right. Like we can walk into it with a much clearer picture of what to expect.
Yes.
Or the other situation is that the baby's born and we have to work on it at that moment in time. But that's a clean slate. That's a new baby, and
clean slate.
Yeah. You're right. It's very nice in a way, because our babies are fairly straightforward.
That's good though. They're babies. That's the thing, you think about adults when they're coding. It's sometimes, if you've got like I had a 104-year-old that we're doing compressions on, and I'm thinking, okay, I get it, family. You love your loved one, but at the same time, it's not to say you shouldn't respect the family's wishes. There's a point where it's like when the first compression you do cracks every single rib in their body, you're like, this ain't gonna turn out well. So for little kids in the code situation, for the neonates, okay, you gotta, I'm still, it's the palm of the hand thing. So you got a baby that's that size. If they code, are you blowing on their chest to get their heart to beat? It doesn't take much, right? You just say, do.
Well, everything's more or less the same as with an adult, but just teeny tiny version.
Yeah.
All of our equipment is super teeny tiny. All of our little blood pressure cuffs and our little heart leads and everything's tiny. I see 10 mil syringes of saline for flushing, and I'm like, whoa.
Yeah.
That's a huge syringe.
Yeah.
Because
that's the volume of my child, right?
We don't deal with those on a regular basis. I see big tegaderms and stuff like that cover my whole patient.
Yeah.
So everything we work with is just super teeny tiny, and you just get kind of used to that.
In what ways can the general public or resources for the general public be improved to minimize the amount of neonatal ICU admits? The first thing that comes to mind for me is the drug thing.
So one of the big things, and this is marijuana is legal.
Yeah.
And people think that because marijuana is legal, it's okay to smoke marijuana when you're pregnant. And so that's been a big thing that we've encountered in these states with legalized marijuana. And people need to understand that it's still a drug. It's still something that can affect your baby. It can affect baby's growth and development.
It crosses the placental barrier.
Yeah. And so it's just little things like that where just taking that extra care to understand that just because something's legal doesn't mean it's right. And doesn't mean it's
absolutely,
okay.
Yeah.
Of course, watching what you put into your body, and great prenatal care is really important. And a lot of places have ways for moms with lesser resources to get in and get seen, and it's really important so that we know as health professionals what to expect when the time comes for you to deliver your baby. A lot of times we get surprises. We're not prepared for whatever
surprises us in. You've never seen this kid before.
Yeah, and mom comes in and she's having this baby and she's never been seen, and there's an issue, there's a defect with the baby that we're not prepared for, and the doctor's not prepared for, and it always makes it easier when we have a record on this mom, when we know exactly how old your baby is because we've been tracking your pregnancy. We know exactly that mom has this weird clotting condition that affects the delivery and the state of the baby. These things are good to know. So prenatal care is really
prenatal care. Don't smoke marijuana if you're pregnant.
Nope.
Okay. What kind of or crack? Crack is usually a good one to avoid, just in general.
The biggest thing that we see kids withdrawing from are opioid painkillers that mom takes, narcotics. That unfortunately is very common in the NICU population anymore, as the opioid crisis tends to go up in the general population. So marijuana isn't one of those things that you'll see long-term effects with the baby once they're delivered, but it's definitely something that can get in the way of their development while they're growing, and so it's best to just avoid all that.
It didn't occur to me, when I think about babies that are addicted to some sort of substance, some sort of drug, and when they're born, I always think of mom is a crack smoker, or she smokes meth, or she shoots up or something like that. But I don't think about the mom that's on chronic opioids or anything like that, because there's certain patients that need pain relief, you know what I mean?
Yeah, you got moms in chronic pain that have to take medication. You also have moms who are in recovery treatment programs and are taking methadone. Your baby will actually withdraw pretty heavy from methadone after it's born. So there's a lot of substances out there that mom takes that are going to cause an effect on the baby. And a lot of times we in the NICU will even cause a baby to have to withdraw. Because if the baby has a very difficult surgery or has a lot of pain, sometimes we'll have to put them on a narcotic pain reliever in order to get them through that process, and then we have to wean them off. Drug withdrawal is very common for this population, unfortunately, but it's we've come a long way as far as ways to treat it, so we're doing pretty good.
It's good, but that's not to encourage anyone to stay.
No.
That can affect them for the rest of their life, right? You fetal alcohol syndrome, being on that fetal alcohol spectrum.
They're trying to find a lot of these correlations between babies who were exposed to drugs, babies who went through withdrawal, and behavioral issues later in life.
Yeah.
They're trying to see if there's connections between those things, because There probably are. So it's
Absolutely, yeah.
something they're doing a lot of research on. But one cool thing is that a lot of people don't know, and maybe you didn't know this,